This is Dr. I'll be presenting abnormal midwifery today. This is for the nursing students. Okay, so abnormal midwifery. We are going to identify and manage and even be able to refer patients with obstetric and medical conditions which are associated with pregnancy, labor, and preparing. You really need to know the distinction between obstetric condition and gynecological condition. Actually, obstetric condition revolve about pregnancy, that is to mean the process of gestation period, the process of carrying the fetus, delivering, and even the postnatal, that is after the birth, all the care that revolves around that, the condition that are associated with the progress of the same. Now, when you talk about gyn is any health reproductive health related condition. Okay, so gynecological, it's in regardless to being pregnant or whether you are just any other condition related to reproductive health, that is gyn. So we're going to check today on abnormal midwifery and its pattern obstetric and medical condition which are associated with pregnancy, labor, and even puerperia. Pregnancy, that is the gestation period, which is 9 months in human being, and then the labor, the process of giving birth or delivering, and then puerperium, that is after the giving birth. So we are going to be in position to even identify and manage patient with obstetric emergencies. Okay, so we have conditions such as preeclampsia and eclampsia, and there are many other conditions which you're also supposed to know, and we're going to check into them. So well, let's start with preeclampsia and eclampsia. Okay, preeclampsia comes before eclampsia, and preeclampsia is clinically defined by hypertension and proteinuria with or without pathologic edema. So let us check on the risk factors for preeclampsia and eclampsia. First of all, it's only preeclampsia and eclampsia when the female gender is pregnant or when we have pregnancy. You'll never get an unpregnant woman with preeclampsia or eclampsia. We don't do that. We don't say that. Okay, so I've said there are clinical indication of preeclampsia, that is hypertension and proteinuria, with or without edema. Sometimes it actually manifests with edema. That is swelling of the limbs, can be bilateral or unilateral, one limb or both limbs. So proteinuria, that is to mean there is a protein in urine. Hypertension, that is to mean the blood pressure, both diastolic and systolic, are elevated to some degree. So what are the risk factors? Risk factors are always things that predispose individual to preeclampsia. These are the things that if you get to realize from a mother who is pregnant, you get to know that there's possibility of this mother, fathering condition into preeclampsia or eclampsia. So one of the pregnancy associated risk factor like hydatidform mole. Okay, when you diagnose a molar pregnancy, that is by ultrasound examination, anything which can rule in mole, there is high risk of preeclampsia or eclampsia. And as I told you, we start with preeclampsia, and then preeclampsia will progress to eclampsia. Talk about multiple pregnancy when the mother is expecting more than one baby. That is can be two, three, four, some even give birth to six. So multiple pregnancy, that is a sign or is a risk factor for eclampsia and eclampsia. Urinary tract infection, history of UTI during pregnancy also is indicative of the same. So talk about maternal specific risk factor. That were the ones we've listed are just pregnancy associated risk factors. So when talk about maternal specific risk factors, talk about extreme age of the mother. That is maternal age around 20, less 20, that is lower than 20 years, that is extreme age, that is very young, it's also a risk factor. And then if you're older than 35 years, ladies who are yet to deliver or maybe get conceive, when you're 35 years and above, there's increase in majority of the things which are actually not good. So first, you are more likely to be infertile. That is to mean that your hormones, which are actually playing role in pregnancy and even managing of the baby during a period, they are now low, and you conceiving, your chances of conception is also low as well. Now you are predisposed to some gynecological, obstetric complications such as preeclampsia and eclampsia and many other. Some are even during the you can have prolonged labor, you can have dystocia, you can have there are several complications that can come with the extreme age. Okay, black race is another risk factor. So in the United States, the incidence of preeclampsia is 1.8% among the white women and 3% African Americans. And then family history of preeclampsia, if there's any relative who had preeclampsia in your family. And then nulliparity. Nulliparity, someone was never given, conceived, okay, or given birth, okay. So more common if you're nulliparity and then it's your first time getting pregnant, or what you call the primigravida, that is that's also indicative or a risk factor for preeclampsia. So you have to watch preeclampsia in previous pregnancy. If you've given birth and you've actually experienced preeclampsia initially, that's also indicative of the same. Talk about diabetes. If you have blood sugars like diabetes mellitus. Obesity, if your obesity, that is to mean your BMI is above 30, okay. So sometimes 35 kilograms more of it will be predisposing or risk factor for preeclampsia and eclampsia. Chronic hypertension and renal disease. So if you have issue with your kidneys, or if you've been diagnosed with the chronic hypertension before the pregnancy or even during the pregnancy, is indicative of the same was the same. So, as I told you, that essential of diagnosis of preeclampsia, it pertains the actually the three or the two hallmarks of the clinical presentation. One is hypertension. That is when the blood pressure is above 140 and 90 milligrams of mercury or more than, but it has to be taken in two occasions, 6 hours apart. Okay, so we check each of them 6 hours apart. If the systolic blood pressure is at 110 milligrams or more on a single location, is also indicative. So if the systolic blood pressure is high, that is also questionable. Okay. Then talk about proteinuria. It's a protein concentration of 0.3 grams per liter or more in at least two random urine sessions collected 6 hours apart. Or if you use a urine dipstick, so when you're doing concentration test, it's 0.3 grams per liter. But if you're using urine dipstick finding trace positive one or more proteinuria, that is plus one or plus two or plus three, that is indicative. So that is proteinuria. Okay. So dipstick is that tendency of just take the stick that is actually calibrated in terms of colors, and when you dip it in the urine, given time duration for each, you'll be checking urobilinogen, proteinuria, ketones, glucose, leukocytes. All those ones are going to be given by some color ranges. So we have positive one in protein, positive two, basically depending on what the color shade will be in the dipstick, in the urine dipstick. Okay, so normally protein is not supposed to be in urine, it's supposed to be completely negative. Okay, so when you find something to do with the protein in urine, number one, talk about the kidneys. Okay, the kidney, the glomerulus filtration, the porousness of the glomerulus. So together the protein now is able to pass, but you see the glomerulus supposed to only filter out some selected constituents, but now if the protein is also leaking, that's questionable. Talk about edema, gradual sudden swelling of the face and legs. Edema is another thing that can come along, because look at this, look at how this happens when there's high blood pressure. Let's talk about chronic hypertension. The heart generates high hydrostatic pressure, which goes into peripheral circulation. So with that increase in blood pressure, we'll have rampant, or what we call severe, blood ultrafiltrated through the kidneys tubules. Okay, so this one will interfere with sieving, or that permeability of the glomerulus. So it will even increase the permeability in a way that the protein can now leak. So when the protein links, we talk about the oncotic pressure in the tissue being rising, or what we call the oncotic pressure. The protein will cause, the protein will cause oncotic pressure on the tissue, the what we call the intracellular cavity. So with this, plasma part of the blood will be attracted or will be pulled to the tissue. So there will be that tendency of accumulation of fluid in the tissue, which will cause edema. So they're just connected. So edema, the gradual swelling of the face, hands, and legs. But whether there is edema or not, that is still quantifying for preeclampsia. Let's talk about eclampsia. Eclampsia now is carried by conversion. Now, fits comes into the three. Can have hypertension, edema, proteinuria, and then the fits comes in. Okay. So impending eclampsia means the the eclamptic fits are likely to occur very soon, usually in a woman with severe preeclampsia. You see how we classify from mild preeclampsia to severe preeclampsia. So impending eclampsia means that the eclamptic fits are likely to occur very soon, and usually in a woman with severe preeclampsia. Symptoms and signs of impending eclampsia include One, severe headache. So the headache is now very, very famous. And then drowsiness, very sleepy. The mother tend to be so tired and sleepy. Mental confusion. Sometimes they even forget where they put their plates when they're in ward. They forget a lot of things. They don't want to talk. They look very confused. Visual disturbance. Some will tell you that they are not able to walk or see clearly, so they can't even go for short calls. You can help them. They might be blurred vision or flashes of light. And then epigastric pain. Some of them have the upper GIT pain. Okay, I mean the upper abdominal pain, and then nausea, vomiting. Some will vomit. Some will just feel the sensation of to vomit, and the sharp rise abdominal pressure, decreased urinary output, and increased proteinuria. So those are the indicative of what we call severe preeclampsia. Hyperreflexia also comes into play. Okay, so that is that. And some people are saying, what is this hyperreflexia? Okay, now when we talk about hyperreflexia, one thing that you need to know about hyperreflexia is that this is just characterized overreactive or increased reflex response in the body, often indicating an underlying neurological condition. It can manifest as twitching or spastic tendency, signaling issue with upper motor neurons, and also loss of control from higher brain centers. Common causes include conditions like amyotrophic lateral sclerosis and multiple sclerosis. If hyperreflexia is observed, it's important to seek now the medical evaluation for the same care. So that is that. Now, uh, another thing here is that you see when you want to classify preeclampsia, mild, severe, and then we go to preeclampsia. So in mild preeclampsia, you get that the diastolic pressure is still below 90, but below greater than 90 but below 100. Okay, that is still mild diastolic pressure. But now severe, it's over 100. Okay, proteinuria is stress plus 1, that is preeclampsia, which is mild, but plus 2 or greater, that is now severe. Now, mostly in mild preeclampsia, you get there's no edema, but it's present in severe. Headache is absent in mild, but it's present in severe. Visual disturbance might be absent. Upper GIT abdominal pain can be absent. Oliguria is absent. Diminished fetal movement is absent. But then these are now present in preeclampsia. Okay, headache, visual disturbance. But now eclampsia, what role in eclampsia is just any fit, that is conversion. The patient presents with conversion, that's indicative of. So conversion may occur in eclampsia. It has to occur in eclampsia. So conversion may occur regardless of the severity of hypertension. They are difficult to predict and typically occur in the absence of hyperreflexia, and headache or visual changes can occur anytime. So conversions are always tonic-clonic, and they resemble grand mal seizures of epilepsy. Tonic-clonic to means we have a tonic phase and clonic phase. Tonic phase is when now the that muscle we call, not actually, it's a bit of contracting, and the patient loses the patient loses the conscious, and then clonic starts. Now the clonic phase is now where you have the rhythmic jerking movements, okay, and the patient there will always tend to bite their tongue. They lose the control of the bladder, and they also confused after that. So tonic clonic, okay. So the seizures may recur in rapid sequence as in status epilepticus, and if it recurs in that way, it can end in death. And conversion may be followed by coma that last minutes or hours, depending on the frequency of the seizures. 25% of eclamptic fits occur after delivery of the baby. So that we call it stage 4. I mean stage 3 and stage 4 of labor. You are supposed to watch if you are you are attending to preeclamptic mother. So let's check. We have always classification. So we have premonitory stage. These last 10 to 20 seconds, during which the eyes roll or stare, the face and the hand muscle may as well twitch. Okay. These are stages of the conversion in preeclampsia. So we have the premonitory stage, then tonic stage. After tonic stage, we got clonic stage, then coma stage. So premonitory stage, the eyes roll, stare, the face and hand muscle may twitch. There is a loss of consciousness. And then tonic stage, the muscle goes stiff or rigid, okay? And the color of the skin becomes blue or dusky. That is cyanosis. Circulation to mean that even circulate the muscles of the vasculature are also contracting. So circulation is impaired. The back may be ached, and the teeth are clenched, and the eyes they bulge. Okay, Then the clonic stage now, the violent contraction, relaxation of the muscle can increase the saliva causes foaming of the mouth. You realize increased salivation, it causes the foaming in the mouth. Then deep noisy breathing, like they produce that increased bronchial breathing. Say we have inhalation of mucus oscillation. This one comes out to aspiration, so you're supposed to watch. And then the face look congested, filled with blood and swollen. Tongue is beaten by violent action of the jaws. Then coma state. This may last minutes or hours. During this time, there is a deep state of unconsciousness. Breathing is noisy and rapid. Cyanosis fades, but the face remains congested and swollen. Further fit may occur before the woman regains conscious. So, history mild to moderate precancer may be asymptomatic. Many cases are detected through routine prenatal screening care. Physical examination like increased BP compared with the patient baselines of greater than 140 to 90 is indicative. Talk about altered mental status, decreased vision or scotomas, hyperreflexia colonus or clonus, okay? And although deep tendon reflexes are more useful in assessing magnesium toxicity, the presence of clonus may indicate increased risk of convulsions and seizures as well. Laboratory studies, we go for lab work, and the complete blood count is also important to check on and rule out anemia infection. Liver function test, peripheral smear is also important to check even to malaria and all that. Liver function test to rule out, the liver enzymes. Serum, to check and check if there is pathological in the liver. Serum creatinine level as well to check on the kidneys. Okay, because you see proteinuria is there, so we have to check. So urinalysis is also proteinuria suggests of preeclampsia is greater than or equal to +1 protein or urine dipstick of 300 milligrams or zero point 0.3 grams per liter or more. Okay. Ultrasonography. This is used to assess state of the fetus as well as to evaluate for growth restriction. So normally we do the BPP, that is the bioprofile, the biophysical profile of the baby, the gross movement, the somatic movement, all that ones. Okay. Then typically we do typically symmetric intrauterine growth retardation is checked. And aside from transabdominal ultrasonography, umbilical Doppler ultrasonography should be performed to assess the blood flow in the in the uterus, okay, and also to the fetus. So general principle, normally we do what, we manage the BPs, then we control the seizures, and then we manage we give the fluid, okay. So first, anticonvulsant, magnesium sulfate is used, and phenytoin, because things to do with diazepam and many other, sodium valproate, they are contraindicated in pregnancy. So magnesium sulfate is used in anticonvulsant and phenytoin. Antihypertensive like adrenaline, labetalol, and nifedipine is also, adrenaline, labetalol, and nifedipine is also used. Get to know the dosage, okay? Get to know the dosage, and then that is that. Normally, as a nurse, you follow the T sheet, so the doctors will always prescribe for you. Loading dose for magnesium sulfate is 4 grams, 20% solution slowly over 15 minutes. Then 10 grams, 50% IM, 5 grams in each buttock with one. This 2% lidocaine. Then maintain a dose 5 milligram. 5 grams intramuscular for hourly. Then we give IV maintenance dose of 1 gram 20 per hour in 24 hours should only be applied if IV pump is available to avoid toxicity and complication of magnesium sulfate. So the IV maintenance is only done when the IV pump is available. Okay. If you are unable to give loading dose, can give loading dose IM only. If conversion require, give additional 2 to 4 grams IV over 10 to 15 minutes. So the most important here is that is loading dose first. That is IV 4 grams, 20% solution slowly over 15 minutes. Then 10 grams, 50% solution intramuscular. Okay, in both buttocks. Then you maintain with 5 grams. So what you need to know: 4 grams loading dose, 5 grams maintenance dose IM. So if the conversion require, you give additional 2 to 4 grams IV over 10 to 15 minutes. If dilation required for IV route, use normal saline, not lignocaine. Don't give lignocaine the IV. That's anesthesia. Monitor vital sign. Check for hourly prior to next magnesium sulfate dose, conscious level, patellar reflex, and urine output. Next, you have to monitor conscious level, patellar reflex, and urine output. Okay. Monitor vital signs. Check for the reflexes, urine output. Very important. Do not give the next dose of magnesium if there is absent knee jerk, urine output less than 100 mils in last 4 hours, respiratory rate less than 16 breaths per minute. So the next dose of magnesium is not given under 1. When your patellar refer there's no knee jerk, the urine output is less than 100 mils in the last 4 hours, and also when the respiratory rate is less than 16 breaths per minute. If respiratory rate is less than 16 breaths per minute, stop by calcium gluconate. So we have IM, IV, 5 milligrams, 4 milligrams, like that. Mild preeclampsia is actually BP of 140 to 90 established if the mother can rest at home. Then that is if in case the mother has mild preeclampsia. Okay, advise patient relative on importance of bed rest. Give oral antihypertensive like alpha methyl or just methyl-dopa to 50 milligram 3 times daily. Maintenance diastolic pressure. Monitor maternal or fetal condition. You can admit if coming too far away from hospital and advise on worsening signs of condition and they need to report if any signs of severe preeclampsia are present. Okay? Advise the mother to take a diet which is rich in protein, fibers, and vitamins but low in carbohydrate and salt. If the mother shows no improvement and facilities or skills to manage severe preeclampsia are lacking, refer to higher level because these are danger. When there is severe preeclampsia, BP over diastolic over 100, admit patient, nurse in a quiet semi-dark room, monitor vital signs, 15-30 minutes, start magnesium sulfate regime, consider timing and mode of delivery, closely monitor fluid intake and urine output, do blood chemistry like liver enzyme and creatinine. If the diastolic blood pressure is 110 millimeters of mercury or more, start antihypertensive drug, adrenaline 5 milligram IV slowly every 5 minutes until the blood pressure is lowered. Repeat hourly as needed or give adrenaline at 12.5 milligram IM every 2 hours as needed. If adrenaline is not available, give labetalol if it happen. If no improvement, refer to comprehensive center accompanied by trained nurse. Okay. Go for help. Maintain open air, control feeds, control the blood pressure, monitor quarter hourly, start IV line, but restrict fluid intake to avoid pulmonary and cerebral edema. This is for eclampsia. You need to call for help, maintain open airway, control the fields, control the blood pressure, and monitor the quarterly hour. Start IV line but restrict fluid intake to avoid pulmonary and cerebral edema. Maximum of 30 drops per minute. Catheterize and closely monitor fluid intake and urine output. Delivery is the definitive treatment for antepartum preeclampsia. Patients with mild preeclampsia are often induced after 37 weeks gestation. Prior to this, immature fetus is treated with expectant management with corticosteroid to accelerate lung maturity in preparation for early delivery. Dexamethasone is also the corticosteroid which is used in this case. So, in patients with severe preeclampsia, induction of delivery should be considered after 34-week gestation. In this case, the severity of disease must be weighed against the risk of prematurity. So, eclampsia is commonly after delivery and has occurred up to 6 weeks after delivery. So, patient at risk of eclampsia should be carefully monitored postpartum. Okay. Okay, so no attempt should be made to insert any instrument into the mouth during the fitting. But during the fitting, you need to loosen the cloth around the neck, administer magnesium sulfate or diazepam as the regime to control fit, aspirate secretion from the mouth and nostril as necessary, give oxygen continuously during fit, and for 5 minutes after each fit. Fitting should be allowed to complete its course without restraining the patient. Privacy and dignity of patient must be observed. Put the screens around her to protect her privacy. So continue anticonvulsant therapy for 24 hours after delivery or last conversion, whichever occurs last. Continue antihypertensive therapy as long as the diastolic pressure is 110 ml or more. Continue to monitor urine output. If urine output is less than 500 ml in 24 hours, limit the amount of fluid intake to 500 ml per 24 hours plus an amount equal to the amount of urine passed. Watch carefully for the development of pulmonary edema, which often occurs after delivery. Monitor carefully until the patient clearly recovering. Consider referral of women who have oliguria less than 100 ml urine output in 24 hours that persists for 48 hours. Coagulation failure, coagulopathy or hemolysis, elevated liver enzymes, and low platelets. What we call the HELP syndrome. Okay, coagulation. So HELP syndrome, we have hemolysis, elevated liver enzyme, and low platelets. So H is for hemolysis, elevated liver enzymes, and low platelets. So persistent coma lasting more than 24 hours after conversions are indicated. Abruption, placenta, renal insufficiency, hemolysis, elevated liver enzymes, and low platelet count, cerebral hemorrhage, maternal death. Those are complications that somebody should check. Okay. rupture placenta, renal insufficiency, hemolytic HELP syndrome, cerebral hemorrhage, and maternal death or fetal demise. Okay. So early detection and frequent obstetric assessment and prompt management markedly improves prognosis. Women at risk of preeclampsia must have preconception care and attend ANC early and regular. A history of preeclampsia increases a woman's subsequent risk of vascular disease, including hypertension, thrombosis, ischemic heart disease, and myocardial infarction and stroke as well. So before the next, after during the day, for some hours, we'll do anemia in pregnancy. So that is where we stop on the preeclampsia and eclampsia.